Let me introduce our speaker today. So Dr. Nickels is an addiction medicine fellow physician at the University of Kentucky Department of Psychiatry. She previously served as the palliative clinical supervising faculty for the University of Kentucky Bluegrass Care Navigators Hospice and Palliative Medicine Fellowship. She provides medical director leadership of the BCN Healing Transitions Program. The program's mission is to link and retain persons with opioid use disorder to evidence-based treatment. She has over 12 years of experience in hospice and palliative care, including pain management, usually in the context of serious or terminal illness. She has been a member of the American Society of Addiction Medicine since 2018 and currently serves as an officer in the Kentucky chapter. Her clinical and advocacy interests are in the intersection of palliative care with chronic pain management and addiction medicine. So everyone, welcome back, Dr. Katrina Nickels.
Thanks for having me again today. Again, I have no financial disclosures. And so last week, we are addressing that acute and chronic pain syndromes in patients with opioid use disorder can be safely and effectively managed using a multimodal approach and not relying only on opioids. And then we talked about some pain syndromes related to opioids and to be familiar with in the context of opioid use disorder to help inform that comprehensive multimodal treatment. Next slide. And so hopefully after last week, you guys would be able to describe somewhat the difference between acute and chronic pain, be able to describe some pain syndrome caused by opioids, be able to understand and define multimodal pain management, and to identify some prescription risk factors for adverse events with opioids, including development of opioid use disorder. And overall outcomes are to identify patient risk factors for those adverse events when they're prescribed opioids for pain, and to discuss pain management strategies in the context of substance use disorder. So hopefully we got closer to that last week. Just an overview. We talked about how clinicians think about pain types. And so in our minds, when we're asking all those questions, we're trying to figure out, is this what we call nociceptive, meaning that the pain signal is coming from the skin and spinal cord receptors, that it can be a heat or cold stimulus or a mechanical like strangulation or compression. And then that can be divided into, is that visceral, internal organs and smooth muscle? Is it something musculoskeletal? And those would help us know what the differential diagnosis is. That's usually in the context of an acute pain. When it lasts for a long time, we do know that in that nociceptive pathway that things can change and become chronic and what we call nociplastic, where the nociceptors at the skin and spinal cord levels kind of change and continue to deliver a stimulus that is being processed as pain, even though there's no evidence of new tissue damage. The other big basket of pain that we look at could be neuropathic pain because of direct injury to the nerves and nervous system. And so that can be in our peripheral nerves of our extremities and spinal cord, or it can be centralized. And that would be like a chronic pain where it's really maladaptive brain pain processing. Next slide. And so what that looks like in a patient-centered approach is not only the external signal in the person's body, but also looking at the total pain experience when we're talking about the brain processing of a signal. So we're looking at the physical piece, the psychological piece of anxiety, depression, fear of ongoing pain and suffering, the social impact of living with chronic pain, some financial employment impacts of that, a change in their role in their family and community. And then, depending on whatever damage or illness occurred that caused that pain, as well as the treatments for it, it might impact fertility and parenthood issues. And then on that spiritual level of purpose when you're living with chronic pain. Next slide. And so knowing that there is a total pain and thinking about all those pathways, the term is called multimodal pain management. So it's not only about the pharmacology or medications prescribed, it's about addressing the physical needs with, we often think about physical therapy, occupational therapy, but that could also be a chiropractor, massage, ice, heat, or adaptive equipment. So you're not continuing to do things that feel painful. Also complementary and alternative medicine such as acupuncture, addressing spiritual needs, and there's some energy-based and therapeutic touch modalities that are not in traditional medicine, but can be very therapeutic. And then addressing the psychology and the change of what this pain might mean for them, cognitive behavioral therapy, acceptance and commitment therapy, mindfulness-based stress reduction. Those are all modalities, as well as education, reassurance, and knowing your body and knowing what those signals might mean. And then talking about social determinants such as food, housing, security, finances, legal issues, any caregiver issues, and those things. And so one of the biggest things in the conversation when you're talking about pain management is what is our goal for any of these options and for the whole package. And then it's constantly setting goals and short-term goals as opposed to that long-term goal. We talked about, sometimes people will have a very, I don't want to say unrealistic, but this big goal of I want to be and feel that I'm in my body when I was 19 years old. But looking at, well, what is the function today that we want to be a little bit better, a little bit manageable? What are the barriers? What tools can we do in that? And is that goal specific? Is it something we can measure? Is it something that we can't, that is attainable and actionable? Is it realistic? And then is it time sensitive? How long will it take with physical therapy before we see any gains? So that we don't get lost in hopelessness that we aren't back in our 19-year-old body. Next. And then the other part of setting expectations, especially when it comes to the medication piece of it, and this often is in opioid-based management, is setting up expectations of how you contact your medical provider. How do appointments work? How does the schedule work? How often will you get refills? How will someone be monitored on how they're doing, and if the risks and benefits of certain medications or interventions, if that balance is appropriate, and communication. And then talking about the safety of the plan and always talking about that this is time limited trial. These are always resetting some goals. And then knowing that it will take a team and it will probably be multiple specialists of different disciplines. And then knowing that since this is a treatment plan, just like any medical plan, that there's an informed consent with potential downsides to it, and especially with medications, any adverse effects, both short-term and long-term on their health. And then always coming up with any kind of safety plan and talking about overdose education, medication storage education, and disposal education. And then always co-prescribing naloxone with opioid prescriptions. Next slide. And then hopefully one of the general takeaways that everyone got last week is that pain is more than physical pain, and that multimodal pain management is the standard of care and best practice. And that setting some functional pain goals should be specific, measurable, attainable, realistic, and time sensitive, and appropriate monitoring and setting up that therapeutic alliance between a patient and their healthcare team is key. So all of those things about agreements and counseling is key. So we'll go ahead and move on to some of the questions that came up, and it was a really good conversation last time. And so after that, I pulled up some really great questions came. I think it was from Mike Getz about specific numbers of people with chronic pain. And so this came from the Health and Human Services. There's about 50 million adults in the United States that suffer from chronic pain. And just under half of them suffer from what we call high impact chronic pain. So motor vehicle collisions, really significant trauma, physical trauma. And for pediatric and adolescents, some papers quote anywhere from 5 to even a third of pediatric and adolescents can suffer from chronic pain as well. And this could include things like, migraine headaches, for example. An estimated 14 million adults are cancer survivors, and, in palliative care, that's kind of the history of when that need was known, because, cancer, 50 to 75% of those people with advanced cancer present with really severe debilitating pain. But we have, advances in medicine, and we have more survivors, thank goodness. But 40% of cancer survivors will have persistent chronic pain after treatment. And then talking about another special population are people living with sickle cell disease that can cause significant pain crises and frequent ER visits. Even though it's usually acute flares, chronic daily pain does affect about a third to almost a half of people, adolescents and adults with sickle cell disease. Next slide. And then, we talked about the opioid-induced hyperalgesia, which is, that chronic exposure to opioids, if either prescribed or taken illicitly, that one's nervous system kind of adjusts, and best way to say it was like reset the thermostat of pain tolerance. And so I was able to find one study that looked at, it was like 3 different groups of patients, about 50 in each, where they were looking at what they called cold pressor test, where how many seconds could people tolerate having their hand immersed in really, really cold water. And so it was people who were continuing to use heroin illicitly, people who were being treated for opioid use disorder, and actually were abstinent and hadn't used anything in at least 5 months. And then people who, and so they're not on any opioid agonist therapy, and then people who were opioid naive. And what they found was, for those who were abstinent for at least 5 months, that their seconds, how many seconds they could tolerate the pain, was pretty close to people who were opioid naive. So it is suggestive that it could potentially be reversible with being off opioids. But that's as far as we've gotten with that. If it's, how long can someone expect to experience it after cessation of opioid therapy? I don't think I have another slide on it. Yeah, here it is, the next slide. So talking about the treatment of the hyperalgesia. So the theories as to how this happens is, you kind of ramped up the pro-nociceptive or the pro-sending the stimulus of pain pathways, which involve different neurotransmitters, different chemicals. So the ones, and I know this is very technical, but some of the chemicals we're looking at are like NMDA, glutamate, spinal dynorphins. There are medications that are NMDA antagonists that they've looked at, but those have really only shown to maybe be effective in like a perioperative setting, when the anesthesiologists give it when they're giving high dose of like say morphine or fentanyl in the operating room, that afterwards patients don't seem to have as much pain when they use that. But in a chronic pain setting, when they're trying to use those medications, NMDA receptor antagonists, it's kind of been plus and minus. There's some studies that say it's been effective and some that aren't. in the case of, and I put in there opioid-induced neurotoxicity, the way I think of that is that's the most severe case of hyperalgesia. Like even to pull the sheet off of somebody's body feels painful, and you can tell that they're toxic because of the buildup of one of the theories as to why this happens is just the rapid accumulation of opioids in its metabolites. And those metabolites can be toxic to the peripheral nerves, and they'll just start having like myoclonus, which basically means just like involuntary muscle movements. In that, that's also where there's some evidence that those medications could work. But just to know that really, if it's going to work, it's going to be in an acute inpatient setting. And then all of these outpatient settings where they're talking about different medications, it's plus minus. But the one thing that we do try to do is just decrease the opioid load to decrease the hyperalgesia, and maybe take advantage of switching to a different opioid so that you can get that dose even lower. And then of course, in chronic pain management without an opioid use disorder, seeing about if that person can manage their chronic pain without any opioids. I know that was a lot, so I'll just pause if there's any further questions about that. One thing I will add about this though is when you're looking at different ways of this pro-nociceptive pathway, there is also a theory that actually buprenorphine, because it's a very special opioid agonist therapy that doesn't just partially activate the mu-opioid receptor, might also be related to spinal dynorphins, might also be an effective way to decrease that pain, and it may actually not cause this the way the others do. Methadone, I've seen papers that say that it does help, and other papers say that it doesn't help, because methadone also is an NMDA receptor antagonist, but I think just at really high doses, because as I told you, that cold pressor test, they've also done that in patients maintained on methadone, and they did show evidence of sensitivity to pain. So I don't know if that's dose related or if that's just also a sign of opioid use disorder, but I feel like I'm getting really technical, so we'll move on. And so how can, the question came up of how can buprenorphine be used to manage chronic pain? So usually we're talking about sublingual buprenorphine, because we're in this forum, most of our clients are people who are living with opioid use disorder. So when I see this question, I guess, and I don't know who asked it, but when it says additional information, I'll go through these slides, and if I didn't answer it, please type up. Next slide. So something to remember about buprenorphine is there's a differential or a difference in the tolerance that people will have for any opioid. And the nice thing about buprenorphine is it has a ceiling on its effect for the respiratory depression. So this graph just shows that the higher dose you get with buprenorphine, and then the y-axis is the ventilation per minute, and do their respiratory drive go down. But the higher you go, it seems to plateau off. It doesn't keep going down on the ventilation. But next slide. But the pain relief you get as the dose goes up, actually it does continue to increase. So even though the respiratory depression as you go higher in the dose stops, the pain relief continues. So a lot of times people will think because of that ceiling, which is why we want to use it for opioid use disorder or really high doses, it makes it safer. It does not mean that you will have a plateau on your pain relief. Next slide. And so because there's evidence of it being safer evidence for it potentially helping with that pain caused by opioid therapy. And there's, evidence that that it's, it's just an analgesic. This is coming from the Health and Human Services recommendation that barriers to getting buprenorphine for the treatment of chronic pain need to be addressed. So their recommendation is to make buprenorphine treatment available for patients and including buprenorphine in hospital formularies. A recommendation to provide coverage and reimbursement for buprenorphine for treatment of both chronic pain and opioid use disorder, instead of making it like step 2 or 3 before after failure of standard other opioids like Lortab or hydrocodone or Percocet or oxycodone or fentanyl. And then to encourage ongoing clinical trials for the use of buprenorphine to better understand what doses we might need and other indications. So next slide. So I know this is very busy, but this was a really good article. It's about 10 years old now. Dr. Miller Davis is a leader in pain and palliative care management. 10 years ago, coming up with a really comprehensive paper as to how buprenorphine could be a better frontline, first-line opioid to consider when someone feels that they need to have opioids on board for pain management. So it has been shown to be effective in managing neuropathic pain. As I talked about, effective in managing the pain caused by opioids, that hyperalgesia and chronic cancer pain. It also has less downside, not only from the ceiling effect on the respiratory depression, but there's been studies in elderly of improved quality of life, less cognitive impairment, not as much drowsiness or falls. When it comes to pain management, it also, we always think about, well, you can't give a medication to help for pain when they're in the hospital while they're on it, but actually it might actually help that other opioid help with the pain piece in an acute pain by its what we call chaperone effect. It just allows increased mu opioid receptor expression for complex pain. It's because it's sublingual, it's not dependent on someone having a functional gastrointestinal system. It may have less of an impact on suppressing hormones, less impact on suppressing the GI tract and constipation. And it is not affected by renal function, and it's safe in liver failure. So, there's just emerging evidence that this could be used and it could be effective for people who are on it for other indications than pain. Next slide. Do we need to speak about the withdrawal difficulty when considering using buprenorphine for chronic and acute pain, assuming there are different levels of difficulty with withdrawal, depending on the, so I guess, tell me if, I guess because you're talking about such the long half-life with buprenorphine, and if it's only going to be short-term for acute pain. Yeah, so for acute pain, since we're thinking that's going to be short-lived, and we know that any long-acting opioid, including buprenorphine, would lead to a level of opioid tolerance. Yeah, I guess I would say if it's safe and going to be short-lived and in close follow-up, would you want to do any long-acting opioid, including buprenorphine? Yeah, probably not. You'd probably stick with the short-term, as low of a dose as possible of other opioids if you feel like you need that for acute pain, as opposed to buprenorphine, because you will have, like the others, you will, other opioids, you will have opioid withdrawal. As far as for considering for chronic pain, if we're thinking chronic pain and long-term opioid prescribing, I mean, yeah, you'll have withdrawal from any of them, but I would say, I know I hear it from patients, but I haven't found any great studies to support that being off buprenorphine, and Dr. Finucchi, if you want to chime in, of being off buprenorphine, that the withdrawal is any worse than being on long-term oxycodone or long-term methadone for pain.
Yeah, I agree. I'm not sure if Mike's question was more the risk of withdrawal if you start buprenorphine. That conversation would be the same anytime you're starting long-term opioid therapy, that the way the medication works actually causes physical dependence. If it's taken consistently, any chronic opioid will do that. And so that's part of the informed consent conversation before chronic opioid therapy would be started. If your question is more about starting buprenorphine and having to be in withdrawal first, that entirely depends on whether the person is already opioid dependent. If they're not already opioid dependent, then there's no withdrawal needed to begin buprenorphine. You could begin it the same way you would any other opioid, starting low and going slow. So people can, they may be in a chronic pain situation taking opioids on occasion, but they're not physically dependent, if that makes sense. So if your body's not physically dependent, then you don't have withdrawal needed before starting buprenorphine.
Let us know if we answered your question.
You did, and it was the first. I meant the first question because, like Dr. Nickels, I hear stories of the difficulty of getting off of or withdrawing from buprenorphine-based drugs like Suboxone, and I didn't know if there was any truth to that versus other opioids, and it sounds like there's not really a difference or a known difference between different opioids being more difficult or easier to eventually get off of. But again, if you're thinking about chronic pain, you might be considering these drugs for the rest of your life, right? If they seem to be effective, there might not be a situation in which you need to titrate off them.
Right. Well, and I mean, and that's the whole dilemma that's come up with the CDC 2016, the Centers for Disease Control 2016 guidelines for primary care clinicians who are considering prescribing opioids long-term for patients with chronic pain is, there was just an overwhelming amount of evidence that the functional benefits for patients really didn't pay off for people being prescribed more than 3 to 6 months, and definitely not at high doses. So I mean, there's still, it doesn't change the recommendation that high dose opioids, thinking that we're providing better pain management, that thought hasn't changed. Buprenorphine could be a great tool in the opioid toolbox when you're rotating. And if it is true that it doesn't drive that hyperalgesia, then that would also help somebody with their taper off all opioids, including buprenorphine. But because of the dependence piece and the withdrawal and that short-lived withdrawal pain that you're going to have with all of them. Now, I haven't seen any, I know we've started talking about initiation and using tiny doses of buprenorphine to start someone on it when they're on other opioids, but I haven't seen, and probably because of all these formulary restrictions and indication restrictions of how to go from sublingual high dose formulation buprenorphine and then using those lower dose buccal formulations for chronic pain, which are lower dose, and then even lower dose is the once weekly patch. What I can say for my patients that I've seen on once weekly patch, if they miss that dose and it was the lowest dose, like a 5 microgram patch, they don't really describe severe withdrawal symptoms and pain. They'll have a little bit of more pain, but they also have chronic pain. But it's not as, it doesn't appear to be as significant as when someone says how badly they feel with, say, a fentanyl patch, and they've missed changing it or something like that. And so that's just one physician's experience of using those very lower dose things. Okay. Next slide. Can you talk more about the pain management options and how decisions are made? So when we're talking about multimodal pain management, you can go to the next slide. So this is a good picture again from HHS on the 2019 kind of response to the Center for Disease Control 2016 recommendations of really trying to talk about providing adequate pain management and not being so opioid prescribing focused. And so this picture is really good at saying, you know, all patients are different. They all have chronic pain that started for whatever reason. And we have, as we talked about the trolley cart, all of these modalities, all these different medications that we can provide patients, but it needs to be patient-centered. So again, it goes to the evaluation. Where do we think it started? What piece of that biopsychosocial dimension seems to be the most prevalent? So what are we going to attack first now? So patient A may be, we think this was an inflammatory muscular pain, and it could use some stretching, and it's very focused on this one section of this person's body. And so we would give that person a non-steroidal anti-inflammatory, like an over-the-counter ibuprofen, prescribe yoga that can be self-managed and allow movement and stretching, and then do a very directed nerve block to that one area that hurts them. But then we might have patient B where the pain's kind of all over, there's no spasms, it's general, kind of both sides of their body. But you know, they're having a lot of associated depression, anxiety, and then they're just staying in bed, and they don't feel like they can perform activities of daily living or something. And so that person, there might be, hey, let's do a very short-term opioid therapy while you're getting physical therapy to tolerate that, knowing it's going to stop, and physical therapy will be your long-term. Get you in with behavioral health, treat some underlying depression, anxiety, or maybe that will also be some psychology-based behavioral health, some cognitive behavioral therapy to help better with that pain perception, remember, because of the brain processing of chronic pain. And so you can just see there that's kind of how the provider, physician, and patient would come up with what's the plan from here. And then the other thing I would add is that's the plan for now and here. And so a plan that we come up with in 2021 may be different from what we need to do in 2022 or 2032 with chronic pain, and that these things can help all along the way. And so this is just to conceptualize, you know, it feels very challenging. Like that other slide looked kind of easy, but it feels very challenging to get all of those different therapies, restorative physical therapy, interventional procedures with injections and pain pumps, and you know, acupuncture. Like I think there's maybe only like 2 like physicians that go through insurance for acupuncture in Lexington, and probably nowhere else in an hour. But stigma, access to care, and education are, you know, just the concepts and topics that need to be addressed as a system as a whole to deliver that. And it seems like everything's being harped on just risk assessment and stigma. But you're right, we need to talk about access to care and education, that there are all these modalities. And then just talking a little bit about interventional procedures. Just, this is a good table to show the degree of complexity. So even things like a trigger point injection, which can be done in office, if it can be in a primary care doctor's office, physical medicine and rehab. There's some physical therapists that are trained on doing just trigger point injections into, like, there's a muscle spasm, or like when you're, say you have a shoulder that hurts, and you just run your hand through, and you'll feel this like almost marble, this trigger point, and they can work on that if that's very painful. They can do localized joint injections in the office. And then some interventional pain offices can do some peripheral nerve injection. And then, like, your orthopedic surgeons, neurosurgeons, as well as interventional pain specialists, they can do these other things like facet nerve blocks, like in your vertebra, in epidural steroid injections. It'll be your anesthesiologist type of interventional pain physician will probably do things like a celiac plexus block is just blocking the nerve bundles that feed the upper part of your stomach. So as people have chronic abdominal pain, it can be helpful for that. And then, there's newer things like prolotherapy and regenerative therapy injections that they can do for to help any tissue damage that is scarred down kind of regenerate, so it's not so scarred in the structure, not allowing good muscle contraction. And then there's the invasive ones where you're going to have like an outpatient surgery procedure where they will stimulate, they'll implant things like a spinal cord stimulator or a pain pump. Next slide. And all of this of how do we pick it? It's going back to the pain pathway. Is it something more at the site of injury and inflammation, right at that joint? Is it more about modulation of that pain signal through the spinal cord? And we're talking about spinal cord stimulators. Is it the pain perception and the phrase we use is catastrophizing of, this is the worst thing ever, this is going to kill me, even though I know this pain isn't something, because they've done all the medical evaluation, that is life-threatening. And, that would be where cognitive behavioral therapy and pain psychology would be chosen as well. And then behavior could be also your movements, physical therapy. So it's just going back to this. And then that also helps us know which medications to try to use. If it's an anti-inflammatory, that's more at the periphery of it, transduction, transmission, or are we looking at more like antidepressants, anticonvulsants in that spinal cord brain pain processing. Next slide. What does access for these different treatments look like? And then, so I was able to find one study that was very interesting just in the past year. Next slide. And so this was a study across 9 states, Kentucky was not included, where the investigators kind of cold called a bunch of pain clinics and asked them what those clinics provided. And this is what they found, is that predominant number of pain clinics would offer those procedures that I talked about. And then the next most popular was offering medication management, followed by those that would offer some procedures and pain management. But when it came to things like complementary alternative medicine, like acupuncture, that they offered that, or massage or behavioral therapy, that was much lower. That was actually like less than 10%. Now with that is saying that these clinics offered it. I think what often happens is that they refer out, like most pain specialists will refer out to like a physical therapy practice that they're familiar with, or so it doesn't quite capture that. But as far as finding a pain clinic or pain center, there's very few that have it under one roof. So I thought that one was interesting, and that was a really good question. I know I gave you that very generic, gosh, probably like a fourth to 50 or to a half actually do it. But I didn't really find how often, or I didn't find a great one that really said how often it was being utilized other than to say it was underutilized. It seemed to be all over the board, but hopefully that helps. That's a good place to start, and a call for maybe having more time for care coordination and navigation, because it's not all going to be delivered under one roof. And so overcoming some overcoming some barriers to getting those different approaches, especially as we saw that pain clinics offering behavioral treatment, behavioral health, pain psychology was so low. And I know our navigators and peer support specialists are trying to help people with this, but thinking about things like telehealth and trying to work on some coverage barriers to get those evidence-based modalities for chronic pain, which is cognitive behavioral therapy, acceptance and commitment therapy, mindfulness-based stress reduction training, and having that. So insurance coverage is an issue, as well as getting access to all of those appointments. But hopefully telehealth will help with that. Can you speak as to how to empower patients to advocate for themselves during an acute painful injury? And so we did talk about kind of asking not to be taken off of their medications for opioid use disorder. I mean, there's not really a strong reason to stop anyone's methadone, and the whole buprenorphine and surgery. I mean, that is evolving, and there's a lot of strong arguments as to why someone just needs to be continued on it. But I think a lot of it is also just what someone's familiar with and what they've been trained with. So if anything, I would say advocating at least that they get restarted on their medication before they're discharged if it is stopped. I don't know if Dr. Finucchi has more familiarity on that acute care side.
Yeah, I mean, there are options. And I think we try to always talk to patients about what the options may be. If somebody's already on buprenorphine and stable, then and they can continue to take a sublingual, if they're on sublingual, and they can continue to take a sublingual medication within a couple of days of their procedure, then generally it's recommended to continue the buprenorphine, because if it's stopped completely, then they will need to be reinducted. If they have some kind of major accident and they're, on a ventilator and such for some period of time, then generally the medication is stopped and then can be restarted. But it's important to talk to patients about pain can definitely be managed while you're on buprenorphine. Buprenorphine, as Dr. Nickels went through, is itself an effective analgesic. And sometimes we split the dosing of buprenorphine to better take advantage of the analgesic properties. You can increase the buprenorphine for a short period of time. Sometimes I've done that for my patients that are stable outpatients and they're having an ambulatory surgery where they know they're going to be discharged within 24 hours, but there's concern about postoperative pain for a few days. And we've successfully managed it with a few days of higher dose buprenorphine split into 3 times a day dosing, for example. And then sometimes people need additional full opioids on top of the buprenorphine, and that's okay too, as long as the buprenorphine prescriber is aware and that the patient feels safe managing it that way. So I think what's really important is to individualize the care and have the conversation with the patient to begin with. And then, you know, all the adjuncts we can also use, like NSAIDs and Tylenol. So those are some of the issues, but I think it's absolutely possible and to manage pain when someone's stable on buprenorphine, or when somebody's not yet stable on buprenorphine. Pain is not something that people with opioid use disorder need to suffer with, and and worry about not having pain or OUD addressed.
Say when you're thinking about preparing, as we said, communication is so key, is, making sure that there is a release of information so that your provider who's managing your opioid use disorder, can speak to the surgeon or hospitalist, or, if something is planned. Sometimes I've seen that there can even be like a preoperative clinic with the anesthesiologist. Sometimes that's not routine, but sometimes they'll do that if there's a particular question, and there are such things as local nerve catheters, localized catheters that can help with pain as well. And then just kind of prompting that someone is open to all of those things and they're aware of that, and they know that everything's going to be addressed. I guess the only other thing I would say is if the patient's comfortable of that release of information would help physicians speak to each other. And so how can a non-healthcare provider help a client dealing with chronic pain? Specifically, if a client is dealing with chronic pain and is afraid that stopping use will make the pain worse, what can I do? And so, a lot of that is what you're already doing, of just supporting someone who's living with opioid use disorder or any substance use disorder. And maybe pain is one of those triggers, and just having that relationship with them that way, as you normally would, of just being very supportive, listening, being present. That's really not that different from chronic pain recommendations for people who are involved and they're not their healthcare providers, of being very present and validating their concerns, and just knowing that they're not alone. Recommendations in the pain management community are also of being very specific about assisting that person. So if you know that they have debilitating chronic pain such that certain movements are very taxing, instead of just saying, if there's anything I can do to help, you let me know. It could be like knowing that, for example, like walking through the grocery store is very taxing. It's, if this is a friend, okay, or someone who has kind of that closer relationship of being very specific of, okay, I'm going to manage having groceries sent, so that you can conserve some of your effort and energy. Not getting to the point where it's what we call enabling or removing their autonomy and independence, but being specific about the assistance that someone will give. But not being a healthcare provider, this again coming from the pain community, saying it's not very appreciated of getting a lot of unelicited suggestions of do this or that, unless it's already something invited. Now, I know that's a bit different maybe for our care navigators who, but they are actually healthcare providers, nurses, who have some expertise in just saying, I know that there are other things to consider. Has there been a medical evaluation in those things? That's a very vague answer. But knowing, we're peer support specialists and care navigators, I would say the biggest thing of helping is to address any barriers that they have to accessing their treatment plan, hearing out concerns, if there's any coaching that can be done for self-advocacy and coaching for some conversations with their healthcare team. And I guess this is a good, it's a question from you, but also a good one maybe for open conversation from the participants here. Yeah, having all the doctors working together with the patient helps, right? So as the provider, helping with coaching those conversations on encouraging that. You're right, and we, in general, that's not done enough. Thanks, Victoria. What resources or information do you have about dealing with the stressors that come with physical pain? And how do you talk to patients about psychological, social, spiritual pain? Are these always paid services? So I'll answer that question. Are these always paid services? So psychologists and licensed counselors and clinical social workers can bill for their services if they're structured to do that in their practice. And then, you know, same with some, there's some bundled payment for kind of social case management. As far as spiritual care, that's usually bundled in the provider's billing if that's offered. And, you know, talking to them about it, about those aspects of pain is, you know, getting into that narrative story of what does that pain mean to you? How's that impacted your life? You know, tell me about your support systems. Walk me through a typical day and week. Walk me through what it looked like before whatever event happened that caused this pain. And then that we can start naming some things there. Next slide. And so these are just some resources that I have found when I've looked through it that seem balanced and a good resource. So practical pain management, I mean, there's a provider like subscription someone can get, but their website is connected with, as you can see, their community advice, you know, chronic pain communities. Most of these, you know, is in the context of usually not substance use disorder in there, but there are a couple of articles in there that do address both. So, you know, that's just one kind of, if someone is really big into educating themselves on their own, I've found this to be, it seems to be balanced. And then, you know, when we're talking about mindfulness-based stress reduction, but in that context of pain. And so the leader in that has been John Kabat-Zinn, and he's had the Wherever You Go, There You Are book. But when we're talking about living in pain and stress, full catastrophe living has been recommended if somebody is into reading. There's lots of apps that do focus on this mindfulness space, meditation to help manage pain. And so I know Headspace has really emerged as being popular, especially throughout the pandemic. And then, you know, what I always tell my patients is you can download it, any of these apps, and they always try to prompt you to buy it, but you don't have to if you're limited. Insight Timer is one that some of the counselors here at UK have mentioned that they recommend as well. Next slide, or I think that was it. Oh, and then for other websites, these are ones that have been sourced by SAMHSA as reliable websites about chronic pain as well. And so we'll refer to these. People with substance use disorder often have social, sorry, I know everyone can read it, but I don't know if people can see the chat on the recording. often have social, psychological, physical, and spiritual pain. Should all treatment programs address all four? We hear from some medication treatment advocates that a primary treatment for opioid use disorder is buprenorphine or methadone. How important are the other types of pain to an opioid use disorder recovery program? Yeah, I mean, I would say a comprehensive plan should encompass some plan to address those. Of course, knowing that this is a chronic management, right? Just like chronic pain can be a chronic condition. So, you know, how much you address each one of those dimensions really is patient-centered, what's happening at that time. Also being mindful of not trying to overwhelm and hit everything all at once. So trying to also prioritize and see which ones have the most needs or are most acutely impacting someone's quality of life. But yes, ideally, having an ability to offer guidance or to offer those treatments, I would say is important in substance use disorder treatment and in pain management treatment. You know, when we're talking about primary treatment for opioid use disorder being the medications is, well, the medications we know have just such strong data of reducing deaths. And so that is like a cornerstone for being life-saving. And then I kind of put on my palliative care mindset of the other pieces are the quality of life. Number one, keep them alive. And so you have to distinguish what is a life-threatening illness and keep them alive. And then food, water, basics, and that physical health. And then, you know, very, very close to that, following up with quality of life and addressing the entire person. So I hope that answered that. Great question. And I guess not only being able to deliver that, but also having a routine assessment of all of the domains of that person. And I should have put the statistic in there, which now that I'm thinking about it would be the most important. But I mean, in opioid use disorder treatment, you know, it's pretty high. I know it's more than 50%, probably in some studies up to like 3/4. If you're looking at like long-term methadone treatment for opioid use disorder, patients are living with chronic pain. So this isn't a rare thing to have to live with both. And it's so hard to separate those symptoms. I guess just final thoughts are, I hope everyone already thought this before they came in, but for anyone who still needed more convincing that pain management is way more than trying to consider what is the opioid dose. And also at the same time, there's not great reasons to force someone who is opioid dependent, who has opioid use disorder, to have to suffer or feel that they don't have any treatment for their suffering.